Hello. Welcome to Module 2, Advancing Patient Safety Through Systems Thinking and Design. My name is Doug Bonnicum. I'm the Vice President for Safety Management at Kaiser Permanente's Program Office in Oakland, California. Prior to joining Kaiser Permanente in 1994, I worked for several years in manufacturing environment, and prior to that was a submariner in the U.S. Navy. Systems thinking and design is an integral component of high-reliability organizations, such as our nuclear-powered submarine fleet and their counterparts above the water like aircraft carriers. Looking back on my experience, I think it was the integrity and robustness of our systems that enabled and encouraged our people to be self-conscious about their beliefs and their behaviors, to question what was going on in the moment, and to have greater foresight of what was to come. This latter state of being is sometimes called mindfulness, and when coupled with high-performing systems, enables organizations to operate in highly complex environments for prolonged periods of time without failure. That's exactly what we owe our patients who trust us with their lives, and that's exactly what we owe our practitioners who come to work every day to help patients heal, and above all else, to do no harm. This particular module examines contemporary approaches to patient safety through an exploration of systems thinking, error theory, and reliable design. You will be introduced to James Reason's Swiss cheese model of organizational accidents, which has been recognized as the defining model for describing accident causation, and will learn strategies for applying this model to identify the underlying causes of medical errors. With a focus on reliability and the principles of reliable design, we will also examine the discipline of human factors engineering and evaluate performance improvement models such as Lean, Six Sigma, and the Model for Improvement. And finally, we will take a look at how application of these methods can lead to improved workflow processes, the reliable delivery of evidence-based care, and a reduction in preventable medical error. Before we begin, let's review the learning objectives for this module. When we are done, you should be able to 1. Outline major principles for system thinking and reliable design. 2. Describe human error categories and explain ways in which human factors engineering impacts safe process design. And 3. Differentiate improvement models that have been utilized both outside and inside of the healthcare industry. To start, it may be helpful to ground ourselves in a couple of quick case examples to help underscore the complexity of our operations and begin to think about what systems-related issues contribute to patient harm. In the first case, a 35-year-old male was seen for his first visit with a new provider and to seek a referral to ophthalmology. At the end of the visit, the provider was reviewing lab results for a different patient, which showed positive fecal blood and anemia, suggestive of an ulcer or cancer, and he mistakenly entered a GI referral for this patient to the lab for a colonoscopy. The referral stated that the patient had occult-positive stool and mild anemia. The patient took off work and prepared himself for the procedure. The day after his colonoscopy, the patient called the provider who made the referral and asked why he was tested for blood in his stool, and if he really needed the procedure in the first place. It was at this time that it was identified that the patient had undergone an unnecessary procedure and that it had been ordered on the wrong patient. In the second case, a 70-year-old female underwent an outpatient surgery for stress incontinence, fallen bladder, and a prolapse rectum. Vaginal packing was placed during surgery and accurately accounted for in the operating room. The patient went to the recovery area and was to be discharged directly home from there. Her doctor wrote an order to remove the vaginal packing prior to her discharge, but he did not communicate that to the patient or her daughter who was waiting. The nurse assigned to the patient was a male. He was working with a female nurse who offered to remove the patient's Foley catheter and vaginal packing. She removed the Foley but got interrupted and forgot to remove the packing. The male nurse assigned to the patient assumed that his colleague had removed the packing and did not double-check this. The patient followed up with her primary care provider 7 days later because of vaginal pain and gauze protruding from her vagina. And finally, in the third case, at a mid-sized hospital with a nearby primary care office, a 52-year-old with a history of GI bleeds and ulcers as a result of taking nonsteroidal anti-inflammatory drugs, or NSAIDs, was mistakenly prescribed an NSAID, in this case ibuprofen, developed a GI bleed, and had to be admitted to the hospital. All three of these cases, although quite different, have a lot in common. They involve patients and family members who trust that the healthcare delivery system will perform flawlessly. They involve practitioners with the best of intentions and a commitment to do no harm. And all can and do occur far more frequently than anyone in healthcare cares to admit. To change the outcome of such systems requires us to think differently about the causes. Arguably, all of these cases could have been prevented with a more vigilant practitioner who was preoccupied with failure, was reluctant to assume or simplify, and was sensitive to the operations and context around them. This mindset has taken commercial aviation, our nuclear-powered Navy, and other high-reliability organizations quite far in terms of safety. But their performance is as strongly tied to systems design as it is to managing the unexpected. If we are to dramatically move the dial on patient safety in healthcare, we have to improve the foundation upon which mindful practices can thrive. We have to advance patient safety through systems thinking and design. As a patient safety leader, systems thinking and design is an essential skill set in your performance improvement toolbox. To help us all get on the same page with some of the terms that I have been using, let's define a system as a composite of people, procedures, and equipment that are integrated to perform a specific operational task or function. Components in a system are interconnected in such a manner as to perform their task or function when input is provided from a source, such as another component, or a human operator. We might think of the reliability of such a system as its ability to perform its function over time under commonly occurring conditions. The reliability of any system can be degraded by hazards. Hazards are simply activities or conditions in systems that pose threat of harm. Preventable injuries to patients typically happen when a hazardous condition inherent in the system is activated or an unsafe act is committed. The condition or unsafe act may set off its own sequence of untoward or undesired events, or it may directly cause the injury itself. In the aftermath of a preventable adverse outcome, safety leaders focus on the set of events that occurred and led to the harm, looking to identify and eliminate the hazard or hazards from recurring. Of course, there are very sound moral, ethical, reputation, legal, and even financial reasons for minimizing the risk of adverse outcomes before they occur. In addition, there are personal ones as well. All of us and our loved ones have already been or will be recipients of medical care. While it may be unfair for us to expect a healthcare system to be 100% safe, that is completely free of all hazards and potential harm, we should expect safety to be an inherent characteristic of our systems that allows them to function as intended under reasonably anticipated conditions with an acceptable minimal level of risk. System safety is a formal, disciplined approach to hazard identification, evaluation, and control. While most patient safety leaders won't be system safety engineers, they can and must learn how to apply a variety of technical, social, and managerial methods to identify, analyze, and control hazards, both before and after adverse outcomes. Now that we have a shared understanding for what we mean by systems in the context of this coursework, as well as the notion of hazards as an activity or condition that poses a threat of harm, it is useful to dive deeper into what we mean by error and see how human error in medicine is often related to the system our practitioners operate within. As noted in Module 1 of this curricula, in 1999, the Institute of Medicine, or IOM, reported that between 44,000 and 98,000 patients went into U.S. hospitals each year, and they didn't come out alive, and it wasn't because they were sick. Their death was a result of medical error. While this report was initially met with some skepticism, it is now widely recognized and accepted. Unfortunately, there was plenty of evidence of this epidemic before the IOM report, and there has been plenty since. And yet the industry has been very slow to make dramatic improvements in patient safety. With an industry filled with professionals drawn to help others who go through intense medical training and are carefully screened for their positions, why is healthcare so dangerous? The first thing we must appreciate is how complex the practice of medicine has become. Even with all the medical research that has been done over the past 100 years, there is still not a high degree of agreement on what constitutes best practice. Diagnosis and treatment are often performed under some degree of uncertainty, and medication monitoring, particularly in the outpatient setting, is quite challenging. For a frontline practitioner, there are always new medications, new technologies, new procedures, and new research findings to assimilate. Patients are becoming increasingly complex, and the diversity of the workforce grows at an increasing rate. providing safe, reliable care has never been more challenging than today. One thing that is clear to all of us working this issue today is that we can't solve our patient safety problems by using the same kind of thinking that created them in the first place. To make things right for every patient every day will require a new way of thinking about error in medicine and a new approach to preventing harm. This new way begins with a deeper appreciation for error causation and prevention. Most preventable harm to patients receiving healthcare today is caused by unsafe acts of the very practitioners who are trying to help them. Unsafe acts may be categorized as either human error, such as slips, lapses, and mistakes, or procedural violations, such as the slow and insidious drift from safe practice over time, or a blatant disregard for important safety rules. Of note, the very same set of mental processes that leads us to make mistakes outside of the workplace, often with little or no consequence to anyone or anything, can be deadly in healthcare. For that reason, it's critical not only to become familiar with the terms describing human error, but more importantly, to understand and control its sources. As described by James Reason in his book entitled Human Error, errors occur because of one of two main types of failures. Either actions do not go as intended, or the intended action is the wrong one. The former situation is a so-called error of execution and may be further described as either being a slip, if the action is observable, or a lapse if it is not. An example of a slip is the inadvertent selection of the wrong medication from a drop-down menu in an automated medical record. An example of a lapse is forgetting to implement a physician order in the desired time window. A mistake, on the other hand, is a failure of planning, i.e. the plan is wrong. This can be either rule-based because the wrong rule is applied, or knowledge-based because the clinician does not take the correct course of action. An example of a rule-based mistake might be getting a diagnosis wrong and so embarking on an inappropriate treatment plan based upon a set of rules on how to proceed. Knowledge-based mistakes tend to occur when clinicians are confronted with what for them might be a new clinical situation. Slips, lapses, and mistakes are all serious and can potentially harm patients, though again, it all depends on the context in which the error occurs. Jim Reason is also clear to point out that the term error does not capture all of the ways in which human beings contribute to major accidents. If to err is human, one may argue so too is to violate. Just observe your own driving habits and those of the other cars on the road, and this notion becomes very clear. Driving above the speed limit, talking or texting on a cell phone, rolling through stop signs or lights on red, and tailgating are all violations and all alarmingly as clear and present as the day. And Reason notes that while errors may be defined in relation to the cognitive processes of the individual, and violations or deliberate deviations from safe practice may be defined with regard to a social context and behavior that is governed by things like operating procedures, codes of conduct, values, rules, norms, and the like, both errors and violations can be and often are present in the same action sequence. I conceptualize this as the perfect storm of preventable patient harm, or if you were still stuck on my driving example, the perfect storm of automobile accidents. The major contribution that Reason has given to patient safety, however, is not his categorization of error types, nor his calling us to study systems and adverse outcomes through an integrated framework of both cognitive and social psychology, but rather his compelling framework for accident causation in complex systems, known as the Swiss cheese model, and his conceptualization of the three principal stages involved in the development of an organizational accident. That is, organizational factors, local workplace factors, and finally, unsafe acts. First, we'll reflect on accident causation in complex systems. Let's consider the delivery of medicine to be the inherent hazard of our industry. Ingesting a medication, having surgery, being placed on bypass, undergoing dialysis, or receiving radiation, for example, all come with significant health benefits, but they are not risk-free. In addition to the hazards inherent to medicine, accident analysis has revealed the human contribution to adverse outcomes predominate. So, to protect the patient from both the intrinsic hazard of receiving medical care and the human condition, which includes our propensity to err and to violate, safeguards must be established to help minimize the risk of preventable and foreseeable injury. Each of the slices of Swiss cheese in this model might be thought of as embodying those safeguards. Taking a step back, reason asserts that the setup for an accident to occur in a system begins with fallible decisions made by its top-level leaders. These decisions are then transmitted via line management and then ultimately to the point of production, or the point of care in our industry, where so-called preconditions or qualities of human behavior and production coexist, including attributes like the level of skill and knowledge of the workforce, work schedules, technology, equipment, and maintenance programs, along with the individual and collective attitudes and motivation of the workforce which create its culture. Ultimately, the commission of unsafe acts, which includes human error, violations, and most often both, can be prevented or mitigated with a variety of defenses, but often these defenses have defects in them too. In summary, reason conceptualized the trajectory of accident opportunity being one which begins with what he calls latent failures at managerial levels, proceeds with complex interactions as the impact of management's decisions get closer and closer to the point of care, and is neither stopped nor mitigated by one or more levels of defense that were designed to reduce the risk of harm associated with unsafe acts in the first place. This is the Swiss cheese model of accident causation. The Swiss cheese analogy here is that all of the holes or defects in the various levels of the system align to turn a managerial deficiency into an adverse outcome, and the challenge for safety professionals is that because that alignment occurs so infrequently, it's difficult to get the organization to attend to the risks. Those that are active and present every day, such as not washing one's hands, and those that are latent or lie dormant in the system, such as the choice of where to place hand hygiene dispensers in the first place. In addition to Reason's contribution to safety science with the Swiss cheese model of accident causation, he used a simple triangular shape to represent the principal stages involved in the development of an organizational accident. This model has 3 levels or sections. At the top of the triangle is the person or unsafe act at what he called the sharp end of care. It's where the rubber meets the road. The local workplace or error and violation producing conditions that impact the worker's behaviors are in the middle of the model. And the organization itself is represented as the base or foundation upon which all of this lays. It is sometimes called the blunt end. The simple structure links the various contributing elements of an adverse outcome into a coherent sequence that runs bottoms up in causation and top down in investigation. Other modules in this program will talk more about other hazard and incident investigation methods such as failure modes and effect analysis, or FMEA, and root cause analysis, or RCA, as well as review how we might better leverage culture, teamwork, and communications to improve performance. The remainder of this module will examine the discipline of human factors engineering and evaluate performance improvement models such as the Model for Improvement, Lean, and Six Sigma for the purposes of applying these principles to improving the safety and reliability of care. In his landmark article, Error in Medicine, published in JAMA in 1994, Dr. Lucian Leap concluded that errors were common, their causes were relatively well known, and that while many errors were caused by activities that relied on weak aspects of cognition, system failures were at the root of most medical errors. The way that I've interpreted this statement is that errors are events whose causes can be identified and mitigated. That means when you review a close call or a preventable adverse outcome, and you conclude that the cause of the event was human error, you have failed the patient and family as much as the individual involved in the event. The error wasn't the cause. The error was an event whose causes can be identified and mitigated. Furthermore, once an error occurs and it reaches the patient, reliable systems have methods in place to detect and further mitigate them before they cause significant harm. That means that our plan for building reliable systems includes a plan for handling how they will predictably and reasonably fail and what our systems are going to do in response. A cornerstone of building safer, more reliable systems is embedded in an understanding of human factors engineering. Human factors engineering focuses on human beings and their interaction with each other, products, equipment, procedures, and the environment. It leverages what we know about human behavior, ability, limitations, and other characteristics to ensure safer, more reliable outcomes. So what do we know about human behavior, ability, and limitations that we must account for to make our systems safer and more reliable? Well, we know that the setup of inadequate sleep is a major factor in human error. For example, employees are more likely to commit human error between midnight and 6 a.m., even when they have slept during the day. And studies have shown that 24 hours of sleep deprivation impacts human performance as much as a blood alcohol level of 0.1 might. So you can deliver a baby, make a difficult diagnosis, or perform a surgical procedure after being up for 24 hours straight. But if you were driving a car with a blood alcohol level of 0.1, you'd be legally drunk. We know that while stress may improve our performance in some areas, it degrades it in others. Studies have shown that stress usually has the largest negative impact on knowledge workers, which would of course be our healthcare workers. And healthcare workers today are seemingly under a lot of stress. We know that in well-practiced, highly automatic tasks, unexpected interruptions are frequently associated with omission errors, either because some unrelated action is unconsciously counted in as part of a task sequence, or because the interruption causes the individual to lose her place on resumption of the task. And as you know from your own personal experience, errors of omission, such as forgetting your grocery list when you go to the store, are much harder to detect and correct until it's too late. We know that we often remind ourselves or tell our staff to pay more attention, to slow down and be more vigilant, but we also know that research on vigilance, or the ability to sustain attention and react to stimuli over time, has shown that performance declines within only a short time after monitoring begins. And oh, by the way, we've known that since the 1940s. And finally, we've known for decades that memory is a very weak aspect of human cognition. In particular, working or short-term memory is extremely limited in its capacity, and so problem solvers are prone to lose items in what's called their stack. Cognitive psychologists have shown that the number of discrete items of information human beings can hold in short-term memory is about 7 plus or minus 2. Humans compensate for the limited size of their working set by selective ignorance and what's called chunking. That may be efficient and may have helped us get to the top of the food chain, but it's clearly not safe. And yet there's very little a human can do about it. It requires a system. As a patient safety leader, you need to recognize what human factors engineers know. We can't change the human condition, but we can change the conditions under which humans operate. The good news is that you don't have to be a human factors engineer to help create a safer and more reliable system. You do, however, have to have an appreciation of the following error-reducing principles that are specifically designed to address human factors challenges, and some familiarity with integrating them into care process improvement models, such as the Toyota production system or lean methodology, the model for improvement, or Six Sigma. Let's talk first about the error reduction principles that patient safety leaders must become comfortable with. This list of 11 is not meant to be all-inclusive, but it's clearly a good start. Number 1, simplification. This is simplifying the structure of tasks to help minimize the load on vulnerable cognitive processes like working memory and to reduce waste. Number 2, standardization. This is about creating standard work, equipment, and materials to better assess and improve outcomes, orient and train new staff, and improve ease of use. Standardization also requires us to clarify roles and responsibilities regarding both routine and infrequent tasks so that everyone is absolutely clear about who is accountable for what and how, where, and when we expect those accountabilities to occur. If it's good for nuclear power plant operations, commercial aviation, and other high-reliability organizations, it's good for us. Number 3, avoiding reliance on memory to minimize the risk of slips and lapses that we spoke about earlier in this module. Number 4, improving access to information and intelligent decision support to improve efficiencies, reduce reliance on memory, and minimize mistakes by improving decision-making. Number 5, taking advantage of habits and patterns to make it easy to do the right thing and to minimize the risk associated with shortcuts, workarounds, and drift from safe practice. Number 6, exploiting the power of constraints and forcing functions to make it hard to do the wrong thing. Number 7, using visual controls to shape desired behavior. Number 8, promoting effective team functioning through enhanced training strategies like simulation, and development of communication skills to better leverage existing resources, minimize errors, and recover from harm. High-performing teams also hold each other mutually accountable and are more capable in confronting each other's violations and drift from safe practice in the interest of patient safety. Number 9, deploying redundancies where appropriate to capture and mitigate an error before it has the chance to do harm. Number 10, eliminating environmental factors that degrade performance, such as clutter, inadequate lighting, excessive noise, and needless interruptions and distractions. And finally, number 11, creating systems that are better able to tolerate the occurrence of errors and contain their damaging effects when they do occur. This includes making the actions and outcomes of practitioners more visible through strategies like redundancies and using substitution and other mitigating strategies to lessen the impact of error. When each practitioner takes personal accountability for what we called in the Navy their own fitness for duty, or their mental, emotional, and physical readiness to do their job, and their organization shifts the focus from blaming individuals for past errors to preventing future errors, systems can be made safer and better patient outcomes will follow. This does not mean that individuals can be careless. People must still be mindful and held responsible for the choices they make. But when an error occurs, blaming an individual does little to make the system safer and prevent someone else from committing the same error again. So how do we make systems safer? Well, I believe it's a combination of 3 things. The first is recruiting, developing, and retaining the best and brightest providers, and creating a learning system that continually sharpens their technical and cognitive skills. The second is through creating a culture of safety that includes placing a premium on teamwork, communication, and adherence to safe practice. And the third is through the design and sustainment of standard work and reliable workflows. Any organization that leads with a core value of patient and family-centered care and has these 3 elements in motion is an organization that is making systems safer. Our focus in this module continues to be on the element of design and sustainment of standard work and reliable workflows, and we will focus the remaining time together on the importance of integrating the error-reducing principles we just reviewed with several care process improvement models. Armed with an understanding of human error and deviation from safe practice, theories of accident causation, management accountability, and error reduction principles, you now better appreciate the challenge of measurably improving the safety and reliability of an existing system. Taking a system as is and making it better requires, interestingly enough, a systemic approach. And as we began this module with the notion of systems, that is where we will end. While there are many ways to structure the improvement process, the final portion of this module will review 3 systemic approaches. The first is the model for improvement, the second is lean methodology, and the third is Six Sigma. The model for improvement was developed by Associates in Process Improvement and is recommended by the Institute for Healthcare Improvement, or IHI. It is a straightforward and effective tool for accelerating change and consists of 2 main components. The first component is framed by asking 3 simple questions. What are we trying to accomplish? How will we know it changes an improvement? And what changes can we make that will result in an improvement? Another way of saying this is, what is our aim? What will we measure? And what will we do to improve performance? The second component of the model for improvement is integration of the plan, do, study, act cycle to test and implement the identified changes. It is utilization of the PDSA cycle that guides the change process and integrates the measurement piece to know whether or not our changes are an improvement. Now, linking this model back to what we previously talked about in this module, the changes that are most likely to lead to an improvement are those that are tightly coupled to the causes of the current state of performance, and those that are strong by their very nature. The strongest changes eliminate the identified hazards completely. Moderate changes control the hazard in some way, making it easy to do the right thing and hard to do the wrong thing. And the weakest changes rely on things like education, vigilance, the intent of the workforce, or changes in policy without redesigning the workflow. Changes can be tested on a small scale using the PDSA cycle. The notion here is that you spend less time meeting and talking about what will work or not, and more time experimenting, evaluating, and learning what does work. When you've done a good job identifying the underlying causes of a problem and you link strong corrective action directly to those causes, so-called small tests inherent to PDSA cycles will allow you to see what will work or not in operations. If this process is used after a preventable adverse outcome, the measures you develop must give management a good sense that the risk of repeating a similar type of event has been significantly reduced. If your measurement can't do that, management should be reluctant to sign off on the corrective action plan. After testing a change on a small scale and refining it through several PDSA cycles, the team can implement the change on a broader scale, including spreading it to other areas where applicable. The second model we will look at is the Toyota Production System or Lean Management Method, which provides a range of techniques to create a more efficient workplace. The intent is to create smooth patient and workflow and eliminate waste in time, effort, or resources to provide services the customer finds of value. In addition, the Lean Management Method values continuous improvement in operational processes and promotes a productive culture across an enterprise. I believe the Lean methodology can be an effective approach for advancing patient safety through process design because it is grounded in standard work, which is a cornerstone of all high-reliability organizations, mitigation, which recognizes errors will continue to occur, but harm can be dramatically reduced nevertheless, and continuous improvement, which is aligned with any organization whose core value includes patient and family-centered care. That is a commitment to the notion that we can always do better for our patients and their families. For organizations such as mine that are not committed to any one particular model, we find that the Lean method is particularly effective when a system lacks standardization and there are obvious opportunities to reduce waste. Like the model for improvement, Lean utilizes quick iterative tests of change or experiments that can allow healthcare providers to improve care processes, eliminate waste, reduce ambiguity, and solve problems in a relatively rapid fashion. When these are the underlying causes of human error, Lean offers a useful approach to improving performance by addressing the activities or conditions that pose a threat of harm. Another module in this coursework will describe in detail how the Lean Management Method has transformed the Virginia Mason healthcare delivery system in Seattle, Washington. The third and final structured approach to improving performance discussed in this module is Six Sigma. Six Sigma is a multifaceted performance improvement strategy that focuses on making every step in a process as reliable as it can be by identifying and reducing defects. You might think of a defect as anything that leads to customer dissatisfaction. To eliminate defects, staff follow a particular sequence of steps to achieve and measure the desired result. This sequence is called DMAIC, which stands for Define, Measure, Analyze, Improve, and Control. Due to the complexity of this process, the effort is often led by an expert or black belt who is trained and certified in Six Sigma's operational excellence ideas. From a patient safety perspective, Six Sigma may be most helpful when high levels of reliability are critical to patient safety and the margin for error is small. One of the things that I find very helpful about Six Sigma is its emphasis on defining the problem. All too often in healthcare, our workforce is off and running, solving a problem for which it really doesn't understand. Patient safety is complex and problem definition is key. While each of the aforementioned models has its differences, what you should remember is that safe, reliable systems typically share the following core attributes: well-defined workflows with clear roles and responsibilities, mistake-proofing principles to include standardization and simplification, and when needed, redundancies, a measurement strategy to communicate performance over time, and finally, team members who share collective responsibility for one thing: safe, reliable care. Let's return to the three cases that we used to kick this module off. As you were listening to them again, remember that we noted while all three of these cases were quite different, they also had a lot in common. In this case, what I want you to think about is whether or not one of the things they have in common is that they are missing one or more of the core attributes of safe, reliable systems we just outlined. In the first case, a 35-year-old male was seen for his first visit with a new provider and to seek a referral to ophthalmology. At the end of the visit, the provider was reviewing lab results for a different patient, which showed positive fecal blood and anemia, suggestive of an ulcer or cancer, and he mistakenly entered a GI referral for this patient to the lab for colonoscopy. The referral stated that the patient had occult positive stool and mild anemia. The patient took off work and prepared himself for the procedure. The day after his colonoscopy, the patient called the provider who made the referral and asked why he was tested for blood in his stool and if he really needed the procedure in the first place. It was at this time that it was identified that the patient had undergone an unnecessary procedure and that it had in fact been ordered on the wrong patient. In the second case, a 70-year-old female underwent an outpatient surgery for stress incontinence, fallen bladder, and a prolapse rectum. Vaginal packing was placed during surgery and accurately accounted for in the operating room. The patient went to the recovery area and was to be discharged directly home from there. Her doctor wrote an order to remove the vaginal packing prior to her discharge, but he did not communicate that to the patient or her daughter who was waiting. The RN assigned to the patient was a male. He was working with a female nurse who offered to remove the patient's Foley catheter and vaginal packing. She removed the Foley, but got interrupted and forgot to remove the packing. The male nurse assigned to the patient assumed that his colleague had removed the packing and did not double-check this. The patient followed up with her primary care provider 7 days later because of vaginal pain and gals protruding from her vagina. And finally, in the third case, at a mid-sized hospital with a nearby primary care office, a 52-year-old with a history of GI bleeds and ulcers as a result of taking NSAIDs was mistakenly prescribed an NSAID, developed a GI bleed, and had to be admitted. While more information about each case would be helpful, I'm guessing that you might suspect what was common in these cases is that one or more of the following attributes was missing: well-defined workflows with clear roles and responsibilities, mistake-proofing principles to include standardization and simplification, and when needed, redundancies, a measurement strategy to communicate performance over time, and team members who shared collective responsibility for one thing: safe, reliable care. It's been said that every system is perfectly designed to achieve the results it gets, and ours are no different. When the types of adverse outcomes that we just reviewed occurred, it's not necessarily by accident, it's by design. In this case, poor design. With that assertion in mind, I'd like to leave you with one final thought. Your role as a leader in patient safety includes improving outcomes through systems thinking and design. You don't have to be a human factors engineer or a system safety expert, but you do have to believe that to err is human, that vigilance and hard work are really important but not sufficient, and that by applying your knowledge of safety science to practice, your organization can and will create a safer, more reliable care experience for your patients. This module provided you a foundation from which to do exactly that. With an understanding of the materials and concepts in the other modules in this course, you should be well positioned to help improve the safety and reliability of care everywhere, every day, for every patient. On behalf of the National Patient Safety Foundation, thank you for participating in this course and for the job you do to improve patient care. It is incredibly important and meaningful work. And while you may never get a thanks from a patient for helping to prevent something that didn't occur, I hope that it brings you joy knowing that your contribution makes a meaningful difference both in their lives and the lives of the practitioners who care for them.